expansive hallway here.
Isn't that, yeah, and it looks actually bigger because of the windows, right? It looks like it just keeps on going. Okay. Well, welcome all. We're so excited to be here tonight at Yale University in New Haven. I've known Dr. Herbst for a long time, and I've been nagging him to do this, and he finally said okay. I'm Bonnie Adario. I'm a 13-year lung cancer survivor. I only have one vocal cord, so go easy on me. My husband thinks that's a good thing. So I'd like to introduce everybody on our panel before we get started. To my right here is just Dr. Justin Blasberg, Assistant Professor of Surgery. And then we have Anne Chang, MD, PhD, Assistant Professor of Medical Oncology, Deputy Medical Officer for Quality, which is awesome. And then right next to Anne is Tom.
Yeah, Tom Finan.
Oh, he's not on the paper. Okay. Okay. Well, welcome. Welcome. Okay. They slipped another one in on me. Okay. 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 To my left is Dr. Roy Herbst, MD, PhD, Chief of Medical Oncology, Ensign Professor of Medicine, Disease-Aligned Research Program Leader, and Thoracic Oncology Program. And we could go on and on and on. He's like on every committee, on every research project in the world. He's
on them together.
He's that, well, yeah, I'm on a couple with you. So, and then we have Dr. Henry Park, MD, MPH, Assistant Clinical Professor of Therapeutic Radiology. And then we have Sarah Goldberg, MD, MPH. Oh no, I'm sorry, Emily. Okay, I'm sorry, Sarah. Sarah Goldberg, MD, MPH, Assistant Professor of Medicine, Medical Oncology. And then we have Emily Duffield, APRN, MPH, which a patient of yours told me tonight when I got to talk to him that he loved seeing you on this panel because he said you humanize everything. So key person on a multidisciplinary team, right? So the whole topic tonight is going to be a little bit about where we've been, which I'll give you a little short intro about, and then we can all jump in. I really like this to be kind of like a fireside chat where you just get so absorbed in what everybody's talking about. It really becomes a really interesting thing. When I was diagnosed 13 years ago, there wasn't much for lung cancer. Absolutely, there was practically nothing. There was carboplatin, cisplatin, Taxol, and that was about it in a couple clinical trials. Tarceva was in clinical trial at the time. So then that was connected to an EGFR marker, and I'm sure there's maybe a few in the room that know exactly what that is. But the good news is more drugs have been approved for lung cancer in the last 2 years than the last 4 decades. So these are very hopeful times for lung cancer, and I hope you all feel even more hopeful tonight after we're finished. I know Dr. Herbst is just back from not only attending but doing a lot of lecturing at the International Association for the Study of Lung Cancer in Yokohama, Japan. So he's going to be full of new and interesting topics and therapeutics and trials. For one of the patients over here asked me about CAR T-cell, and I said, we'll talk about that. That's coming from a patient, right? Okay, so I thought we'd get going, and I thought we would start, from the beginning to the end, and initially talk about early detection. It was like a year ago now, I think, or maybe a little over a year ago, that CMS approved CT screening for early detection for lung cancer. But sadly, it's still not approved for everyone. I personally think anybody that wants to be tested for lung cancer should be, just like all the other cancers. So I'm going to ask Dr. Herbst, do you see a future in blood-based diagnostics or any other potentials in the area of early detection?
Absolutely. So what you talk about with the screening is it's only approved for patients, I believe, 55 to 75 who have 30 packed years of smoking and you have to have smoked within 15 years. So there are many people who are at risk that don't qualify. We were actually just on a call earlier today, and even those who have the ability to take advantage of that aren't. And I think that's very important, the message to get out to the community that screening for lung cancer is important, and then certainly we want to screen all populations. We want to, everyone should have access to this. But I think what you talk about is a good question. What about a blood test? People who might be at risk, maybe not with that smoking characteristics. We know 20% of lung cancer is non-smokers now. So it would be very nice. And liquid biopsies and liquid DNA is really becoming something that we're using so much. In fact, Sarah has done a lot of work in that. Do you want to comment?
Great.
So right now we're using blood-based tests or liquid biopsies, as they're sometimes called, to test people's blood for certain mutations. And right now we're really using it in patients who have more advanced cancers and looking for certain mutations. Really, mainly in patients who have EGFR, but really looking for other mutations as well. We don't know currently how to use it in patients who don't have cancer, but we're looking for the cancer. So that's something that we can't do yet, but it's something that's being looked at and studied, and maybe one day we'll be able to use that instead of right now where we use a CAT scan to try to find cancer, to detect it. Maybe one day we can use it for screening. But currently the way we're using it is in patients who have more advanced disease, already have a diagnosis, using it to see if there's DNA that's shed from the tumor into the bloodstream and see if you can pick it up that way in someone who already is known to have cancer.
Because if a patient didn't have a CT scan yet and you didn't detect it in the lung or anywhere else in the body, because a tumor can shed cells into the blood, something could pop up there that would indicate, let's get a CT scan. Could it lead possibly to us really being able to identify the right people for the right early detection programs in all cancers, rather than people of a certain age getting tested for everything constantly?
Right, so you talk about genetic or risk versus
Yeah.
just risk based on exposure.
Yeah.
We need a model, like of both.
Right.
What do you think, Anne?
I think, can you all hear me all right? So I think that as I don't know. Thank you. As Sarah was saying, as our detection, our assays, the things that we have get better, then we can avoid procedures that are more invasive. So if you can't, in your realm, if you can't get a biopsy and if you can take a blood test, wouldn't that be great if you can actually take that blood test to monitor how your disease is doing? I think that we're doing a lot of clinical trials now at Yale, and so part of what we're testing is we're looking to see how do your scan results look, but also how does that compare with some of those blood tests for these markers, and can we detect things without doing invasive procedures or the scans? The guidelines now, we use the Lowdose CT scans, and those have a third less radiation than your regular CT scans, and so I think that's where we're really trying to push the envelope, is to do things that are less invasive, have less side effects, and really allow people to make the most of their quality of life and not worrying about things.
Yeah. Okay. Thank you. I've got a question for Dr. Blasberg, because we're still talking about early detection and diagnostics early on. Surgery. Are you finding that you're doing a little more surgery on stage 4 patients now than ever before?
So I think in select stage 4 patients who may have a single metastatic lesion somewhere like the brain or the adrenal gland, that we sort of have a steady stream of patients who may sort of fall into that category. I don't think we're operating on more stage 4s. I think we're probably better at picking up stage 4s now than we ever have,
Yeah.
with better imaging technology and sort of the model of using a tumor board to sort of review things as a group to come up with a consensus for working up our patients. But I think there's a steady stream of patients who fit into that category that still benefit from a multimodal approach, including surgery.
Okay, great. That's great news to patients, because 80% of all cancer patients are treated in the community, And not every patient has an opportunity to have a multidisciplinary team like this, all looking at their cancer, you know, making a decision based on consensus. You know, everybody's looking at your scan, everybody's looking at, you know, opportunities and different modalities, and it's really, I think, for patients comforting to know that they've got this many people and this team, you know, working on, you know, what the best treatment plans are for them.
We debate for hours sometimes, you know, what
Yeah.
to do, because you know, I used to work someplace, you know, if you went to the surgeon, you got surgery. You know,
Right.
you went to the radiation oncologist, you did radiation.
Right.
And medical oncologists, we only had chemotherapy. Now we have a lot of other things.
Right.
But really what you need is you need everyone in the same room, hopefully having seen the patient, because there's no substitute for looking at someone, examining them, and then really figure out what the best approach is. And sometimes the order matters, and just looking at it very carefully. The other thing, I think, when you talk about operating on stage 4 patients, you want to give patients the benefit of the doubt. So if you have something that's growing, maybe it's not stage 4, biopsy it and show that it's a stage 3 and treat it more aggressively.
Right.
Or now with some of the therapies we have, like immunotherapy, you might have someone who's doing well at 2 or 3 years, has one side of disease, and we might take it out. We might take out an adrenal gland, or we might take out one nodule on the lung. You've probably done some of those.
You know, and in line with really creating hope tonight, because there's just so much out there, and what Dr. Herbst just said, that really wasn't considered 5-6 years ago, and especially not in a community environment. Since we're still on the subject of diagnostics, who would like to talk a little bit about genomic profiling and biomarker testing and what that is? Who'd like to take that?
I will not be.
Okay. Right.
I'm going to read Sarah. I think Emily should say a little bit about how we use it in practice.
Okay, great.
So it's a big topic. Maybe multiple of us should talk about it. But so this is a key part of what we do every day in practice, especially I think as medical oncologists. So that's why Justin didn't want to answer the question. But actually, he's a key part of it, because what we need, at least right now, for most patients is tissue. So what we need is a piece of the tumor to be able to take part of the cancer cells and dig down to the DNA, to the genes of the cancer, and to really understand what's making the cancer cell grow. And that's usually, in many cases, the certain mutations or abnormalities in the genes or in the DNA of the cancer. And so now we're able to, by very advanced technology, do a panel of genes and test for a panel of mutations fairly quickly, actually. It used to take sometimes months to get these large panels of mutations back, and we'd be waiting for these results, and it would take so long. And now actually very quickly, within sometimes a week or two, we can get large panels of mutations back where we can understand what's making the cancer grow and what's driving it to really be abnormal and be a cancer. And not only do we have that information, sometimes that information can really tell us the best treatment for it. Because if you know what's making the cancer grow, sometimes you have a treatment that can stop it from growing. So it's really, that information is so key to understanding how to best treat certain cancers, especially lung cancers, and how to choose the best therapies. So that's really the genetic testing for lung cancers, and that's really what we've been doing for now many years. It's gotten much more advanced, it's gotten faster, and it's gotten much broader. We used to test for one gene, EGFR, then we tested for 2 genes, EGFR and ALK, and now it's growing and we test for many. And at Yale, we test for, in every patient, we test for 50 or so genes, and then if those are negative, we go even bigger. We test for many, hundreds of genes to find mutations, because when we find something, we very often can act on it. There's also additional tests that we do to look for other markers to tell us if immune therapy might work in patients. So that's also a really important part of testing. That's not looking at the genes, that's looking at certain proteins on the cancer cells. So that's also part of what we do. And all this is really important to understanding what's happening at the level of the cells in the cancer and to picking the right treatments. So
who would like to address the future of genomic profiling? You know, we know where it wasn't years back. We know where it is today. What does the future look like?
I can take a stab at that.
Okay.
So I think we're just at the tip of the iceberg. So we had hoped that we'd profile and we'd find one gene, one abnormality in a cancer, and we'd match it with a drug. And that's happened with a couple of drugs, the epidermal growth factor receptor inhibitors, Tarceva, some of you know it as Aresa, Tagresso, crizotinib, alectinib. That works, but what we're seeing is the tumors become resistant, and tumors are smart. They learn how to get around these drugs. So then we have, the future is going to be monitoring in real time. Oh, yeah, I didn't turn it on. I went to the bathroom. I didn't want to have it on.
That's a good plan.
I've seen that movie. Oh, yeah, that's a lot better. So, oh, that's a lot better.
Is yours on?
Mine's on. Yeah.
I think we have to start the whole program again. So basically, the future is going to be these liquid biopsies. So following in real time, because if you're getting one of these oral drugs, we want to know when are you sensitive, when are you resistant, and we can follow those cells with a blood test in real time. So I think that's one part of the future. The other thing we haven't even begun to talk about is it's not just about the tumor anymore. It's about the immune cells and the microenvironment. So you have a tumor, and then you have all the cells that are making up that tumor, the B cells and the T cells and the immune cells and the stromal cells. So we have to know the characteristics of those cells too, because they're juxtaposed to the tumor, and they're involved in how that tumor grows as well. So the future is going to be total comprehensive profiling of the tumor stroma, the immune cells, the supporting cells, the blood vessels, the tumor, and putting that into a model, and using that model to figure a systems approach to figure out how to treat cancer. And all of us work together, and it's sort of nice that we're in your living room because we're in our boardroom all the time. But we're trying to figure out why are some patients sensitive to these drugs, and some are not, or some are sensitive and then become resistant. What are those mechanisms? Because if we understand the biology, we can understand how to treat the cancer better.
So, oh, I'm sorry, go ahead. Yeah, you certainly can.
So I think that there's the idea of big data. So that we are trying to get more and more data. Everything that you do, you go to the bank and so forth. We're trying to collect that kind of data around the tumor cells and the cancer. So we're trying to figure out what is the signature for the cancer in the future, which can predict how well that patients can do with certain therapies. We're writing a trial right now that is going to go through our cooperative group system that will be for patients who have first-line chemo, and part of that is collecting information on the signature of their cancer. And I'm sure that many of you have heard about personalized medicine, and so that's the other piece. Once you gather that data, can you get more understanding about the individual person, not only your cancer, but how do you react to that cancer? How does a patient be able to, how does their body metabolize the drugs? How does the body react to that particular therapy, if it's chemo or if it's maybe immune therapy? So being able to really tailor that therapy to that person and that person's cancer. And I think that's the really exciting part of the future.
Yeah. You can keep that until we need it again. So recently, we've seen patients with lung cancer. All of a sudden, up pops this mutation that's really never been seen in lung cancer before. It's seen in another cancer. What are we doing about that?
But I can try.
Yeah.
So
yeah, okay.
I think part of what we're learning is that we have to rethink how we talk about cancers, how we categorize cancers. When I started treating cancer patients 30 years ago, you had lung cancer. It was small cell, was not small cell, that was it. You had colon cancer, you had pancreas cancer. And what we've learned is that that is some way true, but what's really the important difference between these different cancers is their molecular profiles and the molecular signature, the pattern of the abnormalities in each individual cancer really tells you what its biology will be, tells you how it will behave, tells you which treatments it will respond to. And that pattern may not, and that may be, you may discover in a lung cancer patterns that say this will respond to a drug that is used for colon cancer, or it may respond to a drug that is used for lymphoma. But the pattern of the abnormalities tell you this will work. And I think that is the part of the goal of the personalized medicine, is to get to that level for each individual patient to say, we know for your cancer, this is the best treatment. And it may not be what you think of as a treatment for lung cancer.
Do you think we'll ever get to the place where cancer is cancer, regardless of the organ that it's in?
Yes and no. I think that certainly with the profiling that we're talking about, we can look at all cancers and do a similar panel for both the genes and for the immune cells and for the microenvironment. However, we're always going to want to have specialists who treat the cancer with the surgery, with the radiation oncology, with the medical oncology, because that's going to remain an important part of things. And then what we're learning is that mutations are different depending on the context. So for example, there's a gene known as RAF, and RAF mutation has been a very different thing in melanoma than in colon cancer, or in lung cancer than in other tumor types. Same thing with a mutation called RAS. So there are lots of differences in how the genes function in the context of what else is going on. So I think looking at cancers, with full profiling is great. It's a piece of information you have, but then you need the surgeon, the medical oncologist, the nurse practitioners, and the radiation oncologists to all see.
Okay, that's great. That's great. We already talked about surgery on lung cancer patients, but what do you see as the future? We talked about what you're doing now. What do you see down the road, 5, 10 years from now?
So I think a lot of the staging is changing in small ways, and I think but for the most part, we're operating mostly on early stage patients. We're using more minimally invasive techniques, robotic surgery, navigational bronchoscopy, sophisticated technology that allows us to sort of make diagnoses easier, make the surgery a little bit easier on us, to be more thorough than we've ever been able to be before, and then to do surgery with smaller incisions so that patients can recover more quickly and get to their other therapies, if it's chemotherapy or radiation or something else. So I think the indications are going to stay the same, but really we're probably the dinosaurs in the group here compared to the innovation and the technology and the future of lung cancer therapy. I think we're still probably on top of the best option for the early stage patients, but as things evolve, that may in fact not be true. So,
well, you mentioned navigationally guided bronchoscopy. What is that?
So we have a technology now where we can not only use a camera and navigate into sort of the larger airways, but then use a CAT scan technology superimposed on the patient who's laying on a magnetic board, and then use a virtual bronchoscopy system to drive out to a peripheral target where maybe we can either do a biopsy or leave a fiducial marker for radiation therapy, or potentially even just to inject dye into that space so that we can, when we're doing our surgery, can identify where something that may or may not, something we may or may not be able to feel, but we can actually then see because there's dye present. So it's one of those sort of new popular technological feats that somebody really smart came up with, and we're able to sort of use that in our space.
I know who that was.
Yeah.
That's awesome. I love that, and I love for us to have done this all down, so we're not using like acronyms and all of the medical words, so patients really understand this. Because one of our hopes for this evening's living room is that all of the questions we're asking, there's lots of patients you're watching, and there's lots of patients dialing in and watching, for them to be able to have a shared decision-making process with their physician, where they can go in, somewhat educated and knowing what's happening out there in the big world today for lung cancer, and feel real confident when they leave their physician's office that they really have a good plan that's based on everything that's new in lung cancer, and we're looking at everything possible for them. So thank you for that. Chemotherapy, can you explain what a combination therapy is? A person 10 years ago might have only had cisplatin and Taxol. Maybe that was the big combination therapy then. But today, lots of other things going on. So what would that look like for a patient if you were having a discussion with a patient right now? You're saying, well, I'm going to use a combination chemotherapy for you.
I can answer that, but maybe Emily, you want to take a shot at that. Well, let's bring her the microphone.
Okay.
Is it on, or do I need to?
Yeah, turn.
Is that working? So I think,
Just hold it close. Emily.
there we go.
There you
So options when you're talking about patients, particularly with chemotherapy, I think, in some cases we can almost explain it as more can be better, not always. But if you're essentially trying to attack the tumor from multiple different directions, you can end up with a better control level and better sort of killing of the cancer cells by using multiple different therapies. And each one works in a slightly unique way, so you don't necessarily have overlapping toxicity, but we end up sort of creating a more harmful environment for that cancer cell, whether we're directly impacting the cancer DNA, maybe we're working to reduce the blood supply that the cancer can get, so we can have multiple directions to try and go after it. And now we're also even looking at not just chemotherapy combinations, but one of the newer regimens is including immune therapy with chemotherapy. So we're really using that newest, latest, and greatest technique to attack the cancer cells and hopefully give these patients a better outcome.
So that leads us to immunotherapy and what that means. What is that? Why is it different than chemo?
Well, so chemotherapy's been with us since the
Dark
60s or 70s. And chemotherapy works. Don't forget that. In fact, when I was a trainee, I trained at Dana-Farber back 20, 25 years ago, we could cure stage 3 lung cancer, and we would point to chemotherapy with good radiation therapy, really working. And we knew that chemotherapy worked in more advanced disease. We also knew that it worked okay, but it was not that specific. So you would, it's sort of like a carpet bomb. You would really try to kill the tumor, but you would get other things as well, the white blood cells, the red blood cells, the platelets, some of the nerves. But it works, and we still use it, and it might even be used with immunotherapy. But now you have immune therapy, and think about it. Who in the audience has ever had a vaccine? I hope everyone, or else you have to leave. But no, we've all been vaccinated from measles, and if you work at my hospital, you have to have the flu, or they'll fire you. But these vaccines work because they stimulate your immune system. And you're not doing anything, you're not giving someone an immune system, right? They all have it. All you're really doing is waking it up so that it will attack that year's flu strain. So really, when we use the immune system, what could be more specific than using a system that's already in place and has been designed? And if you want to learn more, there's an immunology class that meets across the street 3 times a week. And you can learn about it from some of the world experts, how the immune system specifically kills what's foreign but leaves other things intact. So we have that. And the other thing that the immune system has is memory. I have some marks in my arm. I don't know when I got those shots, but hopefully they're still working. And I think everyone probably does. So the problem is, how do we reactivate the immune system? Because the tumor escapes that. So actually, a researcher whose lab is not too far from here was one of a group of 3 or 4 people who, a number of years back, realized that tumors have blockers. So if this is the tumor cell, the tumor makes a blocker that keeps the immune system from killing it. And what we're trying to do now is use drugs, and you'll hear from some of my colleagues about them, that inhibit that blocker so the immune system can kill the tumor. So now you're only going after that tumor, and you're using the power of the immune system. Now, it's not that simple because the immune system was designed to turn off so that it wouldn't go wild when you have an infection, when you have poison ivy, some sort of other insult. So we have to watch for some other side effects. But I think many in this room can tell you, many of the panel will tell you about their experience and how it's transformative. So some of you I know are on these drugs. That what we're seeing now, we didn't see 5 years ago. Not to say 10 or 20. It's really, really great, but we're still at the tip of the iceberg. We're still wanting to do a lot better, but it really has transformed things. And since I've known you, this has all come to when we met a long time ago.
Exactly.
Who would have thought we'd be using
Exactly.
immunotherapy alone?
No one.
To treat
Right.
chemotherapy. to treat
Exactly.
cancer?
No. I didn't even know the immunotherapy wasn't, part of the cancer paradigm in that it could, address it in any way, shape, or form. By the way, anybody can ask any question you want. There's nothing here that can't be asked. Is there anybody in the audience that's on immunotherapy? Would you like to share?
I'd say right about 2 years.
And your name is?
My name is Suzanne.
Okay.
I have felt wonderful on it. In fact, I want to go back on it. I can't go on it right now because I can see the difference in how I feel after 3 months.
Okay.
As opposed to being on it.
Okay.
Very easy process. I mean, I did have side effects, the usual small side effects, but nothing that I mean, if I had to stop, it was maybe for a few treatments.
Okay.
But now I've been off it for a while due to radiation effects.
Okay.
So,
And then
until
what's going
that-
to happen? Are you going to go back on it?
I
or
hope so.
Is it going to be wait and see?
I'm waiting for my next scan. We'll see.
Okay.
So-
Okay. That's awesome.
No, it's been really awesome for me.
Okay. Anybody else? Okay.
Oh.
Here we go.
Hello, everybody. First of all, I'd like to say thank God for Ann Chang, Dr. Ann Chang. That's my doctor. And I've been through chemo, radiation. I'm 3.5 years so far, so I thank God for that. But I got a question with the cells, because I got white cells go up, white cells go down. So, maybe there's a little issue with that, but everything else is good. I'm feeling good. I'm feeling great. It's not too much I could do. It's just the white cells.
What does your doctor say about those white cells?
Excuse me?
He's doing great, Walter. You are doing great.
Dr. Chang gonna fix that. I ain't worried about that.
That's great. That's great.
What do you tell people about their blood counts, Emily, and why do they go up and down?
So we see them go up and down really as a result of the chemotherapy. We know the bone marrow makes all of your different blood cells, and the bone marrow is a site where rapidly dividing cells are present, just like in the tumor cells, you have rapidly dividing cells. So it's kind of this collateral damage effect that we see many of the blood cells decrease with certain different chemotherapy agents, and depending on how we dose them, we recognize that that's going to happen. We space out the doses to allow for recovery, but we do expect that there will be some of these effects as a result of the treatment, and we manage them, and sometimes you do need to adjust the dose to account for how somebody does react to it. But overall, we see, things drop, and they go up, they go down, and we deal with it.
Okay. Thank you. How about chemo combined with radiation? When do you decide to do both, either at the same time or before or after? How do you decide to address that?
We have a radiation oncologist right here.
Well, what?
Sure.
That's awesome.
Radiation therapy can be used in multiple settings, including the early stage lung cancer, as well as what we call locally advanced lung cancers. Some of you may have had stage 3 lung cancer, where the cancer has spread to the lymph nodes, but has not spread further than that. So that's often the setting in which we will use chemotherapy with radiation therapy together. And often in combination with surgery as well, depending on how many lymph nodes and which lymph nodes that the cancer has spread to. So even when the cancer has spread to lymph nodes, when we can use radiation to a slightly larger area than when we have early stage lung cancers, where we can treat just a very small area. Either way, we can use radiation to be very helpful. The other way can also be in combination with chemotherapy or immunotherapy when we have stage 4 lung cancers, in which the cancer is spread outside where it started and also the lymph nodes as well. If there are just very localized areas where we can focus our radiation dose, we can actually help the immunotherapy and the chemotherapy sometimes work better, and vice versa as well. So sometimes even when the cancer has spread to become a stage 4 cancer, we often are called upon to see if we can to help in that sense as well, to a limited area.
Thank you. It used to be, not too long ago, that sometimes when people had early stage and they had surgery and nothing else, that they were thought to be cured, correct? Correct.
And that's still the case often, where surgery alone can be curative for a lot of lung cancers, as can radiation therapy. We use something called stereotactic body radiation therapy, otherwise known as SBRT. Some people call it stereotactic ablative body radiation therapy, or SABR, which is a little bit more of a catchy term. But in either case, for stage 1 lung cancers, where they're very localized and just one spot, then sometimes if the patients are not able to go through surgery, or if they decide not to go through surgery, we have a very good option of using very high-dose radiation therapy in only 3 to 5 sessions, where we can cure most patients with early-stage lung cancer as well. So it's another option on the table that we've been able to really advance in the last 10 years or so, using advanced technology, advanced imaging, that lets us really localize. I was actually speaking with you earlier about how we use 4-dimensional scans now, the fourth dimension being time, where we can actually, as you breathe in and out, we can divide your breathing cycle in 10 phases and actually see exactly where each individual's tumor is moving over the course of the breathing cycle. Before we could do this, all we could do was look at an average CAT scan, the average of all your breathing phases, and see where the tumor, where we think it is. But all of us breathe, and lung cancers move as you breathe. So now we can actually detect exactly how your individual lung cancer moves, for both stage 1 and for stage 3 cancers, really for any lung cancer that moves, which are basically all of them. And we can actually see now how it moves, and therefore radiate less normal lung tissue, and hopefully give less side effects than we used to be able to.
So some of these stereotactical procedures, they're, what, 3 or 4 treatments now?
Exactly. Yeah, we do most of them in either 3, 4, or 5 treatments. Even some research now looking at even doing them in a single large session, a large dose session. So, basically we do this over every other day for about a week and a half or 2 weeks, and you could be done with your treatment without having to undergo surgery. Still, we believe that for most early-stage lung cancers, if you can undergo surgery, or the appropriate type of surgery, then that's the way to go. But this is another good option for patients who either may not be healthy enough to undergo a big surgery, or may choose not to.
The thing is, Bonnie, you don't know which of those tumors are going to be okay and which might come back. And
Right.
A priori, we don't have those markers. So if you have a stage 1 lung cancer, let's say you trip on that long stairway on the way out, don't anyone do that, and then you end up in the emergency room and they find something in your lung and they cut it out, half the time you're done, or even more, but the other half it could come back.
Right.
But you asked about the Yokohama. So
Right.
one thing I remember from there is there was a study which I thought was exceptional. It took patients who got radiation and chemotherapy for lung cancer, and we knew that some of them were going to do well and some weren't. And then it randomized in the trial, meaning half the patients got it, half didn't, to an immune therapy versus nothing. And it sort of makes sense, because if you give the radiation, you're killing some cells, right? And you're releasing the contents of those cells into the blood, and then hopefully the immune system can pounce, but maybe it's blocked because of the mechanisms we talked about earlier. And actually that result improved the outcome by more than 50%. It was
That's
just
huge.
phenomenal. So
That's huge.
that's how we have to, as a group and society, the researchers, and then bring it to practice, integrate these therapies together, because I think we all have to sort of put it all into one puzzle.
Yeah, and that's innovation. So I just had one more question. When somebody has surgery and maybe doesn't have radiation or chemo or anything, and maybe they did, how long do you continue to watch a patient that has been through that treatment?
Absolutely.
Testing.
It depends on, of course, which type of treatment, but we watch people for a very long time, usually every few months to begin with after treatment, whether it's surgery alone or whether it's surgery with any combination of chemotherapy or radiation therapy. But you know, we believe that the most likely time of recurrence is in the first 2 or 3 years, but even beyond that, it's certainly possible to have recurrences. So usually, whatever treatment modality that you receive, we, you know, the oncologist or surgeon who follows along will really see you quite often at least on an annual basis, and usually more frequently early on.
Okay, great. Do you have a question?
Radiation, then surgery is not an option, if I'm not mistaken. Is it the same thing with lung cancer? If you choose to just do the radiation, does that eliminate having surgery at a later point if you need to?
That's not necessarily true, actually, either in prostate or lung cancer. Often that is what we tell patients with prostate cancer as well, that if they undergo surgery and have a recurrence, then radiation is another option for them. Often after prostate radiation therapy, then if they do have a recurrence, we're not quite sure necessarily if it's in the same area or not. If it is, then often surgery is an option. But oftentimes, if radiation doesn't work, or honestly, if surgery doesn't work at that point, then often it's already having spread elsewhere, where some more kind of systemic therapy to the rest of the body may be helpful. But in the case of lung cancer, if the radiation didn't work, then often especially our surgeons here, like Dr. Blasberg, you know, have been able to do surgery in those circumstances if we believe that it's really truly localized in terms of where the recurrence is. Most of the time, though, recurrences, if they happen, radiation and surgery work so well in early stage lung cancer that it typically doesn't grow back in the same place. Of course it can, but usually doesn't. If it does come back, it often comes back elsewhere in the lymph nodes or elsewhere in the body, in which case we'd have to we have to all meet at our tumor boards and discuss again what the best approach is.
So you can see how important it is to have a multidisciplinary team instead of just one person in charge of your treatment program and your cancer, because it's a, did you have something to say?
No, I just some questions here.
Oh, okay, okay.
Thank you. Yes, thanks so much for the inspiration. I have a question for Dr. Park. It's related to the 4D imaging, the fourth dimension being time. Are you keeping a record of these of this imaging process, which can be shared with labs? Because there's a lot of labs who are focusing on the cell level and the molecular level to see how cancer propagates. And it might be helpful for them to have data from actual imaging of actual cancer propagating.
Absolutely. So, you know, there's actually a line of research now in machine learning and deep learning we were speaking a little bit about earlier, where we are actually importing some of these images both from the original CAT scans as well as our four-dimensional CAT scans that we do at the time of radiation planning, and trying to figure out exactly, and also inputting clinical data such as you know, smoking history and other risk factors, but also outcomes as well, and trying to input that all into the computer systems to try to figure out if we can train the computer in an artificial intelligence kind of way to detect where maybe perhaps the most important aspects of treating the tumor are. So especially in these early stage lung cancers, if there are certain areas of either metabolic activity in terms of how the cells are acting, but also in terms of any other factors that we can determine up front. When you combine the imaging data with the clinical data, as well as the outcome data, all together, as Dr. Chang was saying earlier about this concept of big data, I really think that's a big part of the future of this field as well, is to be able to input all of that and train computers that are much smarter than we are in some capacity. You know, the collaboration of humans and computers to be able to figure out what really the next steps are in terms of you know, how to optimize outcomes for each individual patient.
Thank you.
Go ahead. Oh, I keep forgetting we're minus
At the conferences that many of you went to, what were the major takeaways in terms of resistance and targeted therapies, and what clinical trials might be in the pipeline as the next targeted therapy after Tagrisso?
That's a great question. That's
While
a great
she's getting the
question.
microphone, I'll say that we think about this all the time. And the good news is we have the Tagrissos, and the Tagrisso is going to move to the first-line therapy in many cases. But what are we going to do when that becomes resistant? Hopefully in a very longer period of time. But Sarah?
Right, so we ask ourselves that often because this is a really important question. So just to broaden your question, so it's not just, your question is about EGFR drugs, right? So so for everyone else who doesn't know about these specific drugs, so about 10 or 15% of lung adenocarcinomas, that's one type of lung cancer, has this mutation called EGFR, and there are several drugs that can work very, very well for it. And there's other cancers, other lung cancers, like EGFR mutation positive lung cancer. There's other mutations in other cancers that are very similar, where you find the mutation and there are drugs that work very well too. So there's other examples like what you're talking about, where you find the mutation and the drugs work very well. But what you're asking about is, well, what happens when the drugs that work so well stop working? What do we do then? And so what we know about these drugs is that for most people, they work very well initially. And that's because, like I was saying earlier, you find the problem in the cancer, you find the mutation that makes the cancer grow, and you can block it with a drug, and that can work very, very well. The problem is that cancer can sometimes outsmart us, and it can learn how to grow despite these really good drugs. And that can sometimes be far in the future, so these drugs can often work for a long time. But at some point, the cancer figures out how to grow, and then you get resistance to the drugs. And so the good thing is that more drugs are being developed, and then we get the next generation of drugs that can often work, even when the first one didn't work. And those are some of the drugs you were just mentioning. But then what do we do when those drugs stop working? And so that's the questions that we always are thinking about as researchers in lung cancers. What do we do when that drug stops working? And what about that one? And so I think there's several things that are very important to do to figure out the answer to that question. One is to understand what's happening at the cellular level, to understand what's happening in the cells, in the DNA, to know why it's happening. Why is resistance developing? And so there has been some data that's come out recently at some of these conferences, one in Japan, and there was one in Spain just recently too, that we're starting to understand why the cancers are becoming resistant to these drugs. And it's really important to understand why things happen so that you can understand what to do about it. And so there are certain drugs that may work very well after, for example, Tagrisso stops working. But it depends on why the resistance develops in the first place. And so, as I know you know, biopsying the cancer or maybe getting a blood test to look at the DNA in the blood, I think is going to be really important to know why the resistance is developing and what we can do about it. I don't think it's going to be a one-size-fits-all to say, if this resistance happens, we should, if the resistance happens, we should always do this. I think it's going to be more precise than that. I think it's going to be more another example of personalized medicine, where we see cancer growing and we say, let's get a biopsy, hopefully a blood biopsy, just a blood test. We say, this is why it happened, and now we can figure out what to do about it. And so we're trying to understand why the resistance happens, and also designing trials to try to overcome that resistance.
So
Yes, we do. We will.
We already do, actually.
We do. It's true.
We already have trials where we use immunotherapy in that setting, and I suspect there'll be different immunotherapies. We're developing trials with immunotherapy that might not be against the targets we talked about, this thing called PD-1, PD-L1, but there are other receptors like adenosine that's involved in the immune response, so that's being looked at in this setting. We're looking at mice, Katie Paletti, who I think you might know. She is leading the animal work, where we're getting samples. We take samples from the clinic and bring them to the lab, and we have mice that have these different mutations, and working with Sarah in a project on the Yale spore. So we have a big grant at Yale through the National Cancer Institute where we are studying this as one of our main projects. I think you were at one of our meetings once. That's going to be really important. Testing the new combinations, understanding what works, what doesn't work, and then bringing it into patients.
And I think it's a great point, though, that for EGFR, as an example, we've been always focusing on the next EGFR inhibitor. But maybe immune therapy is the way to go even in EGFR mutation lung cancer, because we know immune therapy can work so well in patients. Maybe it's the right thing for EGFR cancers as well, or other mutations as well. And so we do have a study with looking at immune therapy for EGFR positive lung cancer, and we're going to have another study coming as well. And so there will be plenty. It's a very important area that we're studying at Yale.
I've seen a few patients that have had, say, an EGFR mutation, took Tarceva, progressed, went on to some other therapies, and then came back around and started Tarceva again.
That's right. We do see that. Yep, occasionally that does work. I think there was someone in the corner here who's been wanting to ask a question for a while.
Oh, okay.
Is that okay? Sorry.
Sure.
I got a question for the panel. Let me introduce myself. I'm Walter Pearsall, and change patient. I had a good friend of mine that passed away, cancer. I mean, he was doing so good. He was taking chemo, then he was doing good for a couple weeks, and then next thing I know, he just passed away. I don't know what it is. I don't know what it was, or was his body weak, or I have no idea, but gained a lot of weight. He looked really good, but next week he was gone.
Was this a lung cancer patient? Excuse me? Was it someone
Yes.
with lung cancer?
Yes, he was a lung cancer.
But Tom, you take care of a lot of patients. The disease itself and the therapies.
Yeah, I think when people have cancer, there are other things that can happen to them besides the cancer. And we know cancer can predispose people to other problems, blood clots, infections. And I think when people are on treatment, sometimes the treatments themselves can cause severe problems, can even kill patients sometimes from the side effects. So there's always something you have to be vigilant about when you're treating patients, to look for these other related complications of the cancer. Sometimes things like blood clots happen. You have no idea when they're going to happen. You have no way to predict that they're going to happen. People have been looking and have tried many times to say, could you treat people preventatively for blood clots with people with cancer? And it doesn't seem to help very well. So it is an issue when you think someone's doing so well, and all of a sudden they're gone. And I think all of us see that with our patients as well, and I think all of us are upset.
Yes, on this EGFR resistance to medication, is it something where that the cancer cells are learning about the uses of medicine and getting resistance environmentally from outside? Because if you go to patient A and you give him this thing and it works, then you go to patient B and now they have a resistance to it, how is that learned? Have they learned how, this cancer can learn these things? It almost sounds like a Star Trek Borg thing where they learn through the collective. Yeah.
I mean, on one level, it is evolution. You apply selection, you expose a tumor to a drug. One of the things about cancers is cancers mutate. Their genes are unstable. And so when you apply pressure against a specific target, randomly things change. And as some of those random changes let this cancer cell grow, they then take over and grow. And it is evolution happening inside your own body.
Yeah, like Darwinian.
It is Darwinian. It is.
But then there's also some tumors that exist from the very beginning. So you've described basically primary resistance, where it works in one person and not in another because it might exist from the get-go, versus where you treat and under that selective pressure, it develops. And there's a debate in the field. I think both probably occur. It probably develops on the job because the same cancer cell that was already prone to mutations is continuing to mutate, or it might exist from the beginning as well. And we have to be prepared for both. But
yeah, I just saw a lady 2 weeks ago who has an EGFR mutation, and she at the beginning has has a T790, has the mutation that makes her resistant to the EGFR drugs before she was ever treated.
Mm-hmm. But I'll tell you, this mutation has changed lung cancer. The first patients were treated with these EGFR agents 1997, and we treated many, many patients, and we knew that about 10 to 15% really benefited and the rest didn't. But it wasn't until 2004 that mutations were discovered. And now, Emily, I guess everyone that we see, at least with adenocarcinoma, and I actually like to do the squamous too, we try to profile, and we're doing it in less than 2 weeks now, right? Even sooner.
Yeah.
System-wide. So, we're a health system now. So Tom practices out in North Haven. Some of you have probably seen it as you drive by 91. That's our site. So he has the same profiling there that we're doing, if we're on the main campus. And,
or in Torrington,
or in Torrington,
or in Derby, or Waterbury, and our other Smilow care centers as well.
Michelle, you have a question online.
So first of all, there's a ton of people online and love this panel. A lot of your patients, Dr. Herbst. But so Susan has a question. What about the C797 resistant mutation seen in patients on Tagrisso?
That's a very educated question.
Yeah. We have educated patients.
So that's a mutation that's been described in response to Tagrisso. And there are things, we actually just discussed that last Wednesday. Do you want to start?
Here. Right, so that's one of the mutations that we were talking about. I didn't mention it by name, but that's one of the mutations that we were talking about that can develop when someone's on the drug called Tagrisso. And you don't really see that mutation. It's one of the mutations in one of the genes in cancer that you don't see unless someone gets that drug. And so that drug works very well, and then after a period of time, I don't know how long, it depends in particular patients, that mutation can come up in some patients. And so the question is, and it makes it so that the drug doesn't work as well anymore. And so the question is, what do we do about it? And then the answers apply to exactly what I answered for you, which is, right now we don't have another drug that targets that mutation, but that's something that's being worked on very, very much. It might be that a combination of drugs is needed, or it might be that we can go back to erlotinib, and that might work well. So it might be that we can go back to a drug that we used originally. Or immune therapy might be the appropriate treatment for that. So I think this is an evolving story where we didn't even know this mutation existed until recently, because we didn't really use Tagrisso until the last couple of years. So we're really learning so much so quickly, and this is something that's going to be very, very important to understand more about and to figure out how to treat, because we're seeing it, and it's happening, and it's a reason that an important drug isn't working in some people. And we have to figure out the best way to treat it, and we're starting to learn it.
And the blood-based biopsies are huge.
Yes.
They're
so you
just
can find that mutation in a blood-based biopsy. You can. So I've seen that in patients. You get a blood test and you see that mutation is there. Yeah. Not always. Sometimes you still have to get a regular biopsy, but sometimes you can get it with a blood test.
And our hope for blood-based biopsies is less invasive biopsies upon progression and resistance, and getting more to chronically managing.
That's right.
The cancer. Right.
And it's real. That's here.
Yeah.
You're doing it
exactly.
Now. Yes.
Yeah. Yeah.
Would appreciate, and that is when someone is at an inflection point, meaning to say, the targeted therapy is no longer working, and what is the next step, then does the oncologist himself or herself make a decision, or do people who are at this inflection point, their cases go before the tumor board, are discussed, and some consensus is reached about what would be the next best step?
Both, and then there's a third part you didn't mention. That's shared decision making with a patient, because you want to try to eke out as much time on each of these drugs as possible. Medical science faster than ever before is finding these new molecules. You're in trial. But if someone's slowly growing on one of these drugs, we'll discuss it, and then we'll also discuss it with the patient. And very often we do keep these drugs going for, even if it's not working perfectly, but if it's keeping both things going, or maybe it's having effect in the brain, for example. Some of these drugs work very well in the brain, so we keep them going for that.
But to be clear, the cases are discussed with the board. Individual cases are discussed with the board, and that is input into, for the oncologist, who then can talk to the patient about what might be options.
And not just the board. They're discussed with our colleagues at Dana-Farber or at Memorial or at Hopkins. We try to take advantage of everything, and that's where Bonnie and her team have been so valuable, because Bonnie holds meetings, and Bonnie and I, we go to a meeting every year. It's in a nice place. It's in Huntington Beach.
Right.
We can surf if we want to.
Right.
But we don't. But Bonnie sponsors a lecture there every year at the foundation, and we bring someone in. But we bring people together from all different places, and there's a whole morning on EGFR resistance, because it's complicated, but that's okay. The challenge is what we face, and that we have to put all the information together. And I know all of us, the medical oncologists at least, I know I'll send someone to New York if the right protocol is there, and actually they send some people to us, and vice versa.
Well, I think it's comforting from patients' point of view that there's not one pair of eyes looking on their case. There are several levels of eyes looking on your case, and I think that's, from my point of view, could be communicated more strongly to the patient.
I would say that if you are speaking to your doctor and you ask your doctor, will you present my case at the tumor board? Because I think we've tried to do that for everyone, but there are some decisions that are easier to make, and it's pretty obvious what you're going to do next. Some of them are very complicated. Yeah. But if you have any doubt, just ask your doctor, would you present my case at the tumor board?
We talk about you a lot. We have, research meetings weekly. We have tumor board meetings weekly. So we're talking about everybody a lot.
Right.
And the other point that I just wanted to really hammer home is that we talk about a multidisciplinary team, but a big part of the team, the most important part of the team, is really the patient. So, having you show up here, having you show up to the office, your curiosity in terms of learning about your illness, the faith in medicine, being part of the faith that you have in your team and are taking care of you, those are and the conversations when we talk about different treatment options, it's huge. And your input helps us to be better doctors and gives us value in terms of what we do every day. So I think that that's such an important part of the team. So I hope
it's way
had
important.
To get in there.
It's way important. And Roy knows that I am a huge proponent of patients being part of the solution. We talk about translational medicine, from the bench to the patient and back to the bench being the research lab, correct? I think we should be calling it transformational medicine, from the patient to the bench and back to the patient, because the research wouldn't be happening without patients like you donating your tissue and your blood and everything else we can yank out of your body, to find these solutions and do this research and make, this disease. We weren't talking chronically managed lung cancer 5 years ago. It's not going to happen in 5 years, but I think it's going to happen. And it's because you are stepping up to the table and being part of the solution. Yes, you can.
I was very happy to hear you voice what you just said. I'm a cancer survivor, prostate and melanoma, and advocate, and recently switched to being an activist. Okay. With shared decision-making and patient-centered care, we know how important the communication between physician, oncologist, surgeon, and patient. And there was a monograph written in 2007, and there still needs to be a lot done about improving communication between the cancer provider and the patient. And I would like to suggest in the spring putting a face to cancer and have cancer survivors and have one of these living rooms with cancer survivors talking about their journey, what they learned in the process, how they gathered information, how they communicated, how they made the decision, and invite all the residents, fellows, and people in your department to hear firsthand from the patient.
We will commit to doing that. Absolutely. And we've actually done it before. We did it in our building where we work, and we called it shared decision making. And Ben Levy was our moderator, and we had a panel of 4 patients, and it was really well received, and it was fun, and we all had a great night by the time it was over. And the patients were amazing, and they brought to bear some very good issues that needed attention. So,
and if you look at any of the scientific conferences, there are no advocates, there are no survivor panels, and
we're doing that, right? We're doing that.
We're doing that more and more.
It's usually a physician who's also a cancer survivor.
Not always.
No.
So we actually had. I'm glad you brought that up. So we, Yale's a big campus, but we had this summer, middle of June, we had what we call the Lung Cancer Spore Conference. So this grant that we have, we're one of 4 sites in the United States that has this big lung cancer grant. There are many sites that are working towards it. So we had 200 people come to Yale, and we met on the West Campus, which some of you probably know, the old Bayer campus, and we had the dinners here on this campus, and we had at least 10 advocates here. And we had a panel, and they represented different groups. Some of them were people from the local community that we've brought in. There was one patient who I've been treating for 8 or 9 years now. It started when I was at MD Anderson. He came, and we had that panel talk and discuss. Ellen Siegel was here, and who works with a group called Friends of Cancer Research, which if you don't know, I'd urge you to look them up because they're very patient-centered, just like Bonnie's group. So we do have that. The problem we often have is, who do we invite? Because there's so many people that want to come. But advocacy is important because we're talking about profiling and how mutations matter. I can't tell you how many patients come in here and they haven't had their tumor properly profiled. Maybe they've had the liquid tumor biopsy done. It's negative. They don't go ahead and get the regular biopsy because they haven't been advised properly. And so the advocates can help because patients go on the internet. When you're newly diagnosed with anything, and they'll look to people like all of you. So you can help others, and then you'll learn for yourself too.
And I have to also say, pharmaceutical companies and entities in industry like Foundation Medicine and Guardant and places like that, all have patient advocates, in their meetings as well to advance what they're doing. I'm on several pharmaceutical advisory boards redesigning their trials, telling them what's wrong with their trials and changing them to enter this century. And not make them so complicated and
or patient friendly, like you just might put 8 biopsies into a trial.
Right, exactly.
You have to say, hey, what are you doing here?
Right, exactly. Yeah. But and they're always looking for patients, so for input. So there's a lot of that going on. I guarantee you, and happy to talk more about that anytime you'd like to. If you'd like to, be one of those people, on those panels, awesome.
I'd actually love to have more local advocacy for our lung sport.
Yeah.
Everyone's interested.
Jeff, there he is. Okay.
Yes, I would like to be one of those advocates. If it wasn't for Dr. Jennifer Posick at the Winchester Clinic, I probably wouldn't be sitting here today. I'm definitely an advocate for low-level CAT scans. She talked me into having a low-level CAT scan, and she found my cancer. I'm one of Dr. Goldberg's patients, and I'm just finished my third cycle of oncology radiology, and I'm doing well. I'm feeling great, and I'm definitely a proponent for low-level CAT scans. If it wasn't for that, they would have never found I have absolutely no symptoms whatsoever of my cancer. I have small cell lung cancer and limited stage. And if it wasn't for Dr. Goldberg and Dr. Decker, I don't know where I'd be today. So, but anytime somebody needs an advocate, you got one right here.
There you go. There you go. Awesome. And small cell too. That's
Can I bring
huge.
something up?
You can bring
Does
it.
everyone
got
here,
people over here,
you
too.
know Brian and Jen? Where's Brian?
He's over there.
Brian, raise your hand. So, is anyone here part of Brian's groups and know what he's done? Yeah. So Brian, do you want to comment? You know, I'll tell you, when I see a new patient, and Marianne, where's Marianne? I work with Marianne. We call Brian. So Brian, do you want to say a little bit about what you do and as a social worker working with all of us?
Sure. So my role is pretty open-ended. It's sometimes the concrete.
Could we get you to walk over here so we could get you on camera?
Yeah. He's going to be mad at me tomorrow.
Right.
But I think he's very important.
Okay, awesome.
No, there's room on the couch.
There's room.
Yeah.
We've got a very big living room.
See? There you go.
So my role is pretty open-ended. Sometimes it's the concrete. Sometimes it's questions about disability, insurance, transportation. But it's also the emotional impact, including, you know, how a person is processing this information, how they're coping, how their family's coping. So basically, my job is to listen and ask questions and just be available. And you know, it's wonderful to see so many people out here, and that's about it.
Another very important part of the team.
Exactly.
Without a doubt. Without a doubt. Yeah.
Can we have everyone that's part of the lung cancer thoracic top team who's here just raise their hand so everyone can see who's here? Marianne.
Okay.
We have more radiologists in the back.
Right. That's awesome. That's awesome.
It's a very big team and very multidisciplinary, and we're deep in every area. So you can't have a multi-modality team unless you have 5 or 6 of the medical oncologists. And what do we have in radiation now? 3 or 4?
Yeah, about 3.
Right. In surgery, we've just got 4 now.
4.
You know, one guy went to California. I don't know why he'd want to go there from New Haven, but we brought 2 new ones in. That's crazy, isn't it?
We only have one second over there. Okay, 1 second. I promise I won't forget you. We only have about 10 more minutes, and I know we could go longer and change, Michelle said. I do want to talk about clinical trials just a little bit, because I think it's important that everybody here and everybody online knows why clinical trials are so important and how helpful they can be. Because some of the therapies that you're on now were in clinical trials at one time, and you know, proved very effective, and that's why they're part of the standard of care. Can you give people a little, you know, cheerleading shout why they should consider clinical trials?
Right. Who wants to hazard a guess what percentage of patients in the United States are on clinical trials? Who thinks it's 50%? Anyone think it's 25%? 35%? I hear 35%. Do I have a 15%? 10%? 5%? The national average is 5%. At Yale, we're a little higher than that, you know, because so we're probably the patients we see in the 20% range, you know, but it's not as many as you would think. And clinical trials, I think, allow you to get access to newer drugs and newer therapies long before anyone else. So Scott Gettinger isn't here tonight. He's probably still working in the clinic. But Scott, you know, when I first came to Yale to interview in 2010, Scott showed me some x-rays of someone who was on a drug called MDX-1107. You know what that drug is called now?
What?
Nivolumab.
Oh, wow. Wow.
So,
okay.
So,
yeah.
This, I don't know if she's here tonight, but this woman's doing great. You know, she came in with very advanced lung cancer, and Scott offered her a phase 1 trial of this drug that's now approved, and she got it here first. And her cancer had spread, and she had multiple therapies. And by going in that clinical trial, of course, you take a chance, but of course, these trials are monitored, you know. And what you get with the trials, you get a nurse practitioner like Emily, and you'll get a research nurse that works with you, and then all the clinic staff. So they're very closely monitored. So clinical trials can really be important. What we're trying to do now in our thoracic program is have trial options for all stages of disease. So I heard there are concerns about resistance to EGFR. So we need trials for that before we have those drugs approved. Immunotherapies. We talk about how wonderful immunotherapy is, but still only 1 in 5 have that wonderful result. So we've got to figure out what to do for the rest. We have trials. And then what we're trying to do, and Ann and Tom are really involved in this, is you don't just have the trials on Cedar Street or York Street, wherever you walk in. But now you have the trials in North Haven and in Torrington and in Hartford, right, Ann? And the trials offer chances to test new agents. Now, the caveat is there's no proof. If we knew for sure something was the right thing to do, we'd give it to everyone. Because we do worry about side effects. We don't want to have people have side effects or toxicities. But the clinical trials really are the way forward, and groups like Bonnie's and others help us with this. You know, I remember we designed a trial many years ago to collect tissue. So just the ability, a trial could just be, can we have your tissue, and can you sign consent so that we can study it? But if you study 1,000 patients and 500 do well and 500 unfortunately don't, we can figure out why those 500 didn't until the next time we do better.
Right, exactly.
So I've talked enough on this. Tom, you do a lot of clinical trials out in North Haven.
Yeah, and I think, and I have some patients here who are on clinical trials. Yeah, I think it's really, I tell my patients, this is the best way to get your treatment, because it gives you, as Roy said, opportunities to get drugs that you may not otherwise get. It kind of forces us to really take very good care of you and not cut corners and not do anything else.
You do that anyhow, though.
I do that anyway, but, and I think most patients, when I talk to them about them, people are very willing. I think people are really excited about doing this. I actually had our staff put a sign in our lobby, ask your doctor about clinical trials, because I think it's that important. Yeah.
Do you put a lot of people on clinical trials, Emily, you and Scott?
So I know sometimes, you know, you get this diagnosis of lung cancer. It is very overwhelming, and you do rely heavily on your medical team to identify the best treatment. The clinical trials are a great option. Still figuring out where are those clinical trials available, how do you get to that? You know, hopefully we have it here or somewhere locally. You can certainly go on the NCI website and identify things. But I know here at Yale, to help us, I got trained yesterday on a new way of us assigning treatment plans. So you go in and you stage the patient and you say the type of cancer, the stage, what their prior treatments have been, and even now through the computer system, it's kicking out a list of different standard care as well as clinical trial options that patient might be a candidate for. So it's keeping us really all up to date on what are the latest treatments, you know, what do we have available, so that we put the right patient really on the best therapy at whatever point in treatment they are. So,
yeah. Because I think a lot of people for the longest time have thought clinical trials were, you know, that you were somewhat of a guinea pig, you know, and that you didn't see the benefits. And you know, maybe decades and decades ago that may have been the case, but it certainly isn't.
And I tell my patients, you're not a guinea pig, you're a test pilot.
Right, exactly. Well, there you go. That's perfect. That's perfect, yeah.
Yeah, there's also the concern I see sometimes about people thinking that that's the last resort.
Exactly.
But that's not necessarily true at all.
No, and in many cases, it's the first line. Because a patient is so sick, you think, well, let's throw them on the thing that might give them the most benefit, and then we'll work our way through. So it can be anywhere.
You know what else we have here, Bonnie? I wish we had more time. I'd take you over there. We have a phase 1 early therapeutics clinic now.
Wow.
So we have Pat LaRusso and Paul Ader, 2 top investigators in this field. And you know, should the lung trials be exhausted or not quite fit, we have about 40 or 50 trials there of some of the newest drugs and the newest combinations ongoing. And that's one of our fastest growing areas. Those trials are only done on the main campus. Our patients are being sent in from all over Connecticut. Actually, we get people from all over New England and sometimes from even further, because innovation is key.
Absolutely.
As a patient, I know you would want someone who's innovative, caring and compassionate, and able to really explain it to you in a way that makes sense.
Yeah, and get you excited. I've got this gentleman back here in the green shirt. Are you sure? I promised you. Okay, okay.
So Kathy and I are lung cancer survivors. We were here in 2010, just as you were coming on board. And so what I wanted to say is we have watched Yale evolve specifically in the lung cancer. I think did you were in front of the tumor board as well? I went in front of the tumor board.
I don't think I did.
No. Kathy came down originally from surgery at Brigham. I had surgery here. And every time, we've talked about this, every time we come in, honestly, you guys are getting better. Things that were done before are more precise or evolved so that the team is more involved, the patient is more involved. You mentioned Dr. Gettinger. I would come in with a 3-inch binder and question him on all sorts of things, which he said he appreciated. I think he's lying to me. And so looking, as a patient up at Yale and seeing what's going on, I see great hope. I think there's some unbelievable things that are going on, and the talent that's being brought into Yale is very reassuring for Kathy and I as far as lung cancer survivors. So my hat's off to you guys for that. Go ahead.
I know Dr. Herbst's posse,
Yeah.
Outside of Yale.
Yeah.
And they are some of the top thought leaders in the world.
Yeah.
I mean, not just in the U.S.
And we're just
but
down the road, so we were
out-
very excited
so,
to have you guys on our doorstep.
He also, outside of tumor boards, he reaches out to his peers when he's got a tough case too. So, and they all do it. It's personalized medicine. It's about you personally.
So
Each
here's
one
my
of you.
quick question. With the success that you're having in lung cancer, I'm 5 years NED, and Kathy's 6 years NED, 7 years NED. So, are we worried about it coming back, or how are we approaching those things? I know we're sort of in the trenches diagnosing and attacking immediate cancers, but we're starting to see success like breast cancer has seen, and which I think is amazing. So, is that a worry? Do we continue to get blood testing to see if there are any possible recurrence in tumors? And so, what is that future out? As you guys are all going to get there, you're all going to be NED for 5 and 6, 7+ years. What is the protocol? Is there a protocol?
That's a question.
I think it's being worked on to some, I think one study that we're doing now in our department is circulating tumor DNA. And looking at that to see after treatment what kind of, if there are any signals in the blood of actually the tumor DNA themselves that you might be able to detect. So I think that's one potential avenue in the future that we're collecting data on now. It's one of the trials that we have for a lot of our patients who come into our radiation oncology clinic. We ask them if we can collect their blood very early on, as well as in follow-ups afterwards as well. To we don't have the data analyzed yet, but we're still collecting this information, and we'll see if that for longer-term survivors, which we didn't have as many of many years ago, or even just a few years ago, but now as we are having more long-term survivors like yourself, I think we are really collecting more data that will help us in the future to figure out exactly what the right protocols are moving forward.
I think it depends too on what you had, whether it was surgery and radiation, or whether you're on an immunotherapy or a targeted drug. But for surgery radiation, I don't know what the others think, but I always thought of 5 years as a pretty good milestone. And then you also, like anyone else, you have to worry about other types of cancer. You've had one. Is there any increased risk, or even if someone had smoked and they stopped smoking, you could have risk. For some of the other more advanced disease where you're on an immunotherapy or a targeted agent, there I would look at it as you're living with your cancer. And what's wrong with that? People live with diabetes, people deal with hypertension. So with the targeted drugs, the oral drugs, you just take that every day when you take your other medicines. And for the immunotherapy, we're still learning how long to treat. Sometimes we do have to take people off and then we can put them back on. But again, we're hoping that the research we're talking about here will stay ahead of everyone and allow us to figure out, okay, if it starts to grow again, what do we add? But we'll add it in a scientific way. There are 2 ways to do clinical trials, and there are a lot of clinical trials out there. You can find clinical trials all over, but you have to look at the clinical trial and say, does it make good sense? Is it looking, if you have a trial where you're actually looking at the tumor, so Dr. Kim is in the back, that tall guy in the very back, so he's a great interventional radiologist. So what we can do is, if you come in, we can get a piece of the tumor, and look at it and say, okay, this is up, this is down, and then you get a trial that's somewhat more focused on that. But I think that's a very good question.
Yeah. Yeah, you know, in someone who's had lung cancer several years ago, I usually keep getting scans, even many years out, because there, just as Dr. Herbst is saying, there's always a risk of another cancer. So I usually keep getting scans. I don't know if that's everybody's practice,
Another
but
primary or something. Yeah.
yeah.
Why not?
So you just, it's just like you always get your mammograms, you always get your CAT scans.
Yeah.
So I usually keep looking. But usually the 5-year mark is usually when we consider people cured of their early stage lung cancer. But now we're in a great way. We're getting to 5-year marks with people with stage 4 cancer, which we, I don't know if I've been doing this long enough to say we, but we, the collective we, didn't used to see that, the 5-year mark for people with stage 4 cancer. So it's amazing that now we have that, and now we're getting to even more than the 5-year mark in a lot of patients. So it's really an amazing time for lung cancer treatment.
It's a hopeful time. It is. It really is. Can you just CAR T cell? That's a big buzzword out there right now. Does anybody heard of CAR T cell?
Well, so that's something I just want people to know. So I have a number of hats here. So one of my hats is, lung cancer, and then another, the whole medical oncology. But also in my role with the Cancer Center, we're very interested in developing these CAR T cells and these cell therapies. So that's the next step. So, can you actually, what I've talked about and what we've all talked about is reactivating the immune system. But sometimes it needs a little bit more of a nudge. Maybe you don't have those immune cells already attacking the cancer. You've got to develop them. So what's happening, and it's mostly in liquid tumors like leukemia and lymphoma, if you know that on that tumor there's a protein, you can actually take a patient's own T cells, take them out, and then what you do is you reinsert a new gene into that cell. Now how you do it? You do it with a virus. There are different viruses, and you actually take the cells out of the person, you infect with a virus that actually puts a new receptor in. So it actually makes that immune cell target the tumor. So you've used recombinant genetics to do this, and then it targets the tumor and it kills it. You actually grow them outside the patient and you give them back. That's called CAR T cells. It's been used very successfully. Some of you have probably followed Kite and Juno and some of these companies which are doing it against something called CD19, which is a protein that's very important for lymphoma. I think we can probably do that for lung cancer. We're actually recruiting right now to look for someone to do that here. We've had 4 or 5 people up from the top universities around the country, because we think that can be done not only in the liquid tumors, but also in lung cancer. Could you imagine if we took someone's lung cancer, we sequenced that tumor, we found that there were a couple of unique proteins, and then we actually took out that patient's cells and retargeted them and reprogrammed them so that they can go after the tumor. It's not so far off, and there are many other things in between that we can do, to rev up the immune system. So I think it's all very, very exciting, and these are approaches. You have to be very careful how you use them. They can't be done, at all places, because there are side effects, and you have to look at the brain and the lungs, and there are syndromes that can develop. But progress is being made, and people like Mario Snow, who some of you might know, he's very involved with that, and Scott's been working on that, and Sarah and others. So that's the future. Maybe when you come back to our living room.
Yeah. Our living room. Now it's our living room.
Well, I'm thinking this.
I like it.
I'm thinking this building's so nice we have to annex this to the Cancer Center.
Right. There you go.
And it's all green here.
Right. Exactly. Exactly. Well, on that note,
can I do one thing before?
Of course you can.
So before you end, Bonnie, first of all, this is a real honor to have you and your team here. And for us at Yale, someone commented that we've been improving, and I hope we are. But the fact that Bonnie Adero and her team come here to do a living room, that you're in the main thing. So next time, I want you to go home and remember us. So what we have for you is we have for you, and it's just from all of us, the official Yale Cancer Center, Smilow Hospital fleece.
That's awesome. I will wear it proudly.
For those winter days in California.
I will wear it. I'll wear it the next time I'm with one of the Davids.
But now,
Anything? Yeah. Okay.
Yeah. But now I'll let you conclude. But really, thank you, Bonnie.
Oh, thank you. Thank you all. Thank you. They're nothing without us. Nothing. Awesome.